Hello all, welcome back. It's been a very long break, but I didn't get time due to certain other things which I've been engaged with to upload any video on YouTube. But I'll be getting back to uploading all the Emree which I've been preparing for the past few months. I have made certain medicine related topics because I've been uploading other pediatrics, OB/GYN and surgery topics even previously. You can watch it in my channel. But especially medicine related content and the previous year questions along with his explanation will be coming on the way in the channel, and also you can post FAQs related to Emree, whatever you have doubts regarding its preparation, how to go about it. And I'll also be sharing my Emree journey alongside, but today let's talk about dermatology and we'll cover the portion quickly. We'll be covering all the past questions under dermatology in this module. So we'll be covering these topics, like we'll be going from the very basics of layers of skin, then going to hypersensitivity reactions, certain conditions like urticaria, eczema, acne vulgaris, then hypopigmentary lesions like melasma, albinism, vitiligo, then scaly lesions, itching lesions like psoriasis, lichen planus, pityriasis, skin infections which can be bacterial, certain fungal infections, particularly the dermatophytosis, photosensitivity, bites, and everything we'll cover. Pruritus and skin cancers also we'll be covering it along this module. So before getting started, you have to know what are the layers of skin. Okay, so the layers of skin are mainly three. One is your epidermis, the middle layer is the dermis, and the inner layer below the dermis you have the hypodermis. So dermis being the middle layer, anything above dermis becomes epidermis, that is above the dermis, and below dermis becomes hypodermis, that is below the dermis. Further, epidermis is divided into five layers: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Stratum corneum is the topmost layer. That is the keratinized layer which is constantly shed. So there is a turnover rate from the basal layer which is having the stem cells, and that is where the new cells are being generated. It comes all the way to the top and then it finally gets shed. In psoriasis-like conditions, what happens is this turnover rate becomes so much high that in 3-4 days you'll have the whole turnover happening. That is why there is extensive scaling. Stratum lucidum is not found in all parts of the body, it's only found in palms and soles. Skin is the largest organ in our body, right? So skin is everywhere, but the layer which is just below the stratum corneum, that is stratum lucidum, is only found in palms and soles. Then we have the granulosum layer where we have the keratohyalin granules. Then we have spinosum where there is abundance of desmosomes. Stratum basale, just like we have discussed, there is where the new cells are being generated, that is, the stem cells are present in the stratum basale, along with the melanocytes. Melanocytes are the cells which are producing melanin, and melanocytes give so many projections to different keratinocytes. So it's not 1:1 ratio, it's almost 1:30. So one melanocyte can give projections to almost 30 keratinocytes, and that is how the vesicles are called the melanosomes, and the pigment is called melanin. So any change in this melanin content or the melanocyte number or even the melanosome projections, anything can lead to the defect in this pigmentation and can lead to hyperpigmentation. The dermis has again the papillary dermis and the reticular dermis, and it is in this dermis where you have these skin appendages. Here you can see the hair follicle here. Okay, this is a hair follicle. These are like some sweat glands. Sweat glands which directly opens into the skin are called eccrine sweat glands, and there are some glands which open into the hair follicle which are called apocrine sweat glands. Then we also have the sebaceous gland. So that is the skin appendages in the dermis. Now in the hypodermis or the subcutaneous tissue is where we have the neurovascular bundle. You have the blood vessels, the nerves, and that is called the subcutaneous tissue. And the inflammation of the hypodermis is otherwise called panniculitis. Okay, again we can see the different layers of skin here where you have the dermis, and above the dermis all these layers are of the epidermis. The upper desquamating cells The shedding layer is called the stratum corneum, where you have the keratinocytes. Then you have stratum lucidum in palms and soles, and you have granular layer where you have keratohyalin granules. Then there is stratum spinosum, where there is abundance of desmosomes. Desmosomes are interconnections between the different cells. That is called desmosomes. And you have the stratum basal, where you have the stem cells and the melanocyte as well. Before we go into proper dermatology, different conditions, we have to understand certain terminologies. What do you mean by a lesion? What do you mean by different kinds of lesions, which are like raised lesions, flat lesions? The terminology, the different names are very, very important, because that's how you describe certain conditions. When you say extensive scaling, you have to think about like psoriasis. When you say like vesicles, like you say red things, on dewdrops on a reddish base, you're talking about chickenpox. So there is a like word description for different conditions. So that is very, very important. So once you have your skin, if you have a very flat lesion, you call it either a macule or a patch, and that depends only on the size. A flat lesion which is very, very small, less than 1 centimeter, called a macule. More than 1 centimeter is called a patch. Papule is when you have the lesion a bit raised from the skin. Okay, it's elevated, palpable lesion, so you can feel it. You just not see it, you also feel it. Now that lesion, if it's very small, it's called a papule. Now if it's large, it's called a plaque, like you see in plaque psoriasis. Vesicle is when you have, so you have your skin layer, and then you have a very small fluid filled. The other one was simply raised, it was not containing any fluid. Now this fluid filled blister, if it's less than 1 centimeter, it's called vesicle, like you see in chickenpox. And if it's more than 1 centimeter, if it's a big fluid filled blister, it's called a bulla, like in bullous conditions like bullous pemphigoid and pemphigus vulgaris. You have a cyst when there is an epithelium lined sac containing material or fluid, like your pilonidal cyst. Pustules is when instead of the fluid it is containing pus, okay, like in pustula psoriasis. Wheal is a very characteristic lesion of urticaria that is called wheal hives or wheal or urticaria. Scale is when there is extensive shedding of the stratum corneum, the topmost layer, which is a natural process, but the shedding, the turnover rate becomes so high that the top layer is extensively shed, and that is flaked off, and that is called scaling, like seen in scaly conditions like psoriasis. You can even have scaly lesions and so like in planus and all, but mainly when you say silvery white scales, you're talking about psoriasis. Crust is when there is some kind of an oozing from a lesion and then they dry off. So that oozing can be of dried serum, blood, or even pus, like you see in case of a honey colored crust, which is characteristically described in case of a bullous impetigo, which is a bacterial infection. Ulcer is when there is a defect in the epithelial layer, that is the topmost layer, is called ulcer. Now this bed sore, which is a kind of ulcer, can have different grades, also grade 1 to 4. If it's only affecting the epithelium, it's called grade 1. If it's involving even the dermis, it's called grade 2. If it's involving deeper, it's called grade 3. If all the things are being exposed where you can see the bone, it's called grade 4. That is in case of bed sore, okay? Even you can have a diabetic foot ulcer as well. Lichenification is when there is, due to constant scratching and itching, you're having thickening of the skin. That's called lichenification. You can see different things over here. This is called a very small non-raised lesion, which is flat lesion less than 1 centimeter. It's called a macule. Bigger one, it's called a patch. When it is a raised lesion, it is called a papule, but you have to feel it to see if it's fluid filled. If it's fluid filled, it's called a vesicle. Now this one here is silvery white scales, which is seen in psoriasis, and this lesion is characteristically called a plague because it's a raised lesion which is bigger enough, more than 1 centimeter. Fluid filled lesions called vesicle, which is bigger enough, then it's called a bulla. Sorry about this, okay. So this bigger lesion is called a bulla. Okay. Now here you have pus-filled lesions, which is called a pustule. This one here is urticaria, that is called wheal. Here you can see crusting, okay, and you can also see this is actually crusting, and this is scaling. Okay, so there are two bullous conditions. One is pemphigus vulgaris and other is bullous pemphigoid. There is slight uh, similarity and slight difference in between the two. Bullous pemphigoid is having tens bulla. So when you just touch it, it's not going to burst. So those are tens bulla. Okay. And pemphigus vulgaris are flaccid bulla. They rupture very, very easily. And usually the pemphigus vulgaris can involve the mucous membrane as well. So there can be oral lesions. But in bullous pemphigoid, usually the oral lesions are absent. Now, it is like an autoimmune condition. Autoantibodies in pemphigus vulgaris is against desmoglein 3, which is like the component of desmosomes, which is found in the stratum spinosum layer. In bullous pemphigoid, this is against the hemidesmosomes. Now, hemidesmosomes are between, you have two layers, right? Like you have the epidermis here. Suppose you have the epidermis here, and you have the dermis layer here. In between these two, when there is connection between the cells, it is called the hemidesmosomes. Okay. In between the cells in the stratum spinosum, when you have some connections, interconnections, that is called the desmosomes. Pemphigus vulgaris, there is antibody against desmosomes, and the component which is usually affected in pemphigus vulgaris is desmoglein 3. In other condition where there is pemphigus foliaceus, it's desmoglein 1, but the more common one. Vulgaris means common form, right? Acne vulgaris means common form of acne. So pemphigus vulgaris means common form of pemphigus. That is against desmoglein 3, which is a component of desmosome, which is in between the cells in the stratum spinosum layer. Hemidesmosomes is between the epidermis and dermis. So the blister location is going to be intraepidermal in case of pemphic. It makes sense because desmosomes are in the stratum spinosum layer, which is within the epidermis layer. But in bullous pemphigoid, it's going to be subepidermal because hemidesmosomes are between the epidermis and the dermis. And the blister is going to be dense and firm in case of bullous pemphigoid. It's going to be flaccid in case of pemphigus vulgaris. There is another important sign which is seen in pemphigus vulgaris, which is called Nikolsky's sign. That is, if you just give a tangential pressure to the skin around the lesion, there is going to be the skin is going to get separated. That is called Nikolsky's sign. And Nikolsky's sign is found positive in pemphigus vulgaris. And pemphigus vulgaris has a poor prognosis compared to bullous pemphigoid. Now we'll see another question, and how do we go about solving that. A 24-year-old man presents with chronic intensely itchy rash on his elbows, knees, and buttocks. So in dermatology, what are all important? The age group is important. The description of the lesion, whether it's itchy, whether it's scaly, whether it's plague, macule, that description is important. The distribution is important, like whether it's on the extensor surface and exposed areas, on the flexors, that is important. Any other aggravating factors like photosensitivity, that is important. That will help you to come to a diagnosis. Examination reveals clusters of vesicles. So the morphology of lesion is important. That is vesicles here and excoriations on this area. So that means it is intensely itchy and pruritic. That is why there is excoriations. He also reports occasional blotting and diarrhea. So that is another additional condition which may or may not be associated with this dermatological condition. So we're going to examine this question and see what it is about. The options are atopic dermatitis, dermatitis herpetiformis, psoriasis, and scabies. We'll see this. A chronic intensely itchy rash on elbows, knees, and buttocks. So this distribution, along with involvement of buttocks, with intensely itchy rash, which are like vesicles, with excoriations, is classical of dermatitis herpetiformis. There is another clue here, that is, there is occasional blotting and diarrhea. That means dermatitis herpetiformis, autoimmune condition, often associated with celiac disease. So that is like the skin manifestations of celiac disease. So this bloating and diarrhea is suggestive of celiac disease, which is another autoimmune condition. So this is talking about dermatitis herpetiformis. We'll exclude the other options. Atopic dermatitis, usually they are in the flexor aspect. They are again intensely itchy. There can be like due to extensive scratching, there can be lichenification, but usually there will be history of atopy, usually in the in the younger age group. It can be in adults also if it's being prolonged for a very long time, but there usually will be history of allergy. Psoriasis, the description entirely is different. It's not vesicle, it's going to be silvery scaly lesions, which are again can be intensely itchy, usually on the extensor surface. If it's on the flexor, it's called an inverse psoriasis. So usually it's on the extensor surface. Scabies, the distribution is called the circle of Hebra. It can involve your underarm, it can involve the under the breast, or along the genitalia, the groin areas. Okay, and it's going to be extensively itchy. And there can be like burrows, which are like the characteristic lesions in scabies is called burrows, which can be seen in between the fingers, the finger web areas. So that is classical of scabies. So this question is talking about dermatitis herpetiformis. So the answer is dermatitis herpetiformis. It's a chronic autoimmune blistering disorder associated with celiac disease. So there is grouped vesicles and papules on extensor surface. It can include elbow, knees, buttocks also, especially buttocks also, and scalp. There is severe pruritus. On immunofluorescence, there is granular IgA deposition in the dermal papilla. Antibody is anti-TTG antibody. That is like the screening investigations for celiac disease, also for dermatitis herpetiformis. Treatment is going to be gluten-free diet. That is the first thing you do. Gluten rich diets are barley, rye, oats, wheat, and you can also give dapsone. Why others are not the option? Atopic dermatitis usually involves the flexural areas. There is a history of atopy. Psoriasis is plague lesions, usually with silvery scales, and scabies are burrows and involvement of finger webs, and it's often contagious also. Now let's see another question. A 24-year-old woman presents to emergency department with sudden onset shortness of breath, wheezing, generalized urticaria, hypotension 20 minutes after receiving an intramuscular injection of penicillin. Which of the following is the most appropriate next step in management? So what does it seem to be? So this is coming with a sudden onset shortness of breath, wheezing, urticaria, hypotension after receiving injection of penicillin. So penicillin known case of anaphylactic reaction in some patients who are prone for allergic response to penicillin. So this is a case of clear-cut case of anaphylaxis. Okay, anaphylaxis, which is like an acute hypersensitive immune response against any kind of a foreign substance. It can be a drug, it can be like pollen, okay, anything the patient is allergic to. So this is anaphylaxis. And what is the management of anaphylaxis? This is like a frequently asked question in all of the entrance examination. So your treatment of choice is intramuscular adrenaline. And what is the dose? 1 in 1000. That is the strength of adrenaline that you give for anaphylactic shock. 1 in 1000 IM, intramuscular dose of adrenaline. So the answer here was intramuscular adrenaline. What is the dose? 1 in 1000, 0.3 to 0.5 mg. It's a first line and life-saving treatment in case of anaphylaxis. It should be given very, very immediately. You don't have to secure an IV line, nothing. You have to give them IM. Antihistamines are in steroids. They are only adjunctive. They are not first line. And IV fluids can help with hypotension, but they are only secondary to adrenaline, especially when it comes to anaphylactic shock. Let's talk about the hypersensitivity reactions, one which we have seen now. It's anaphylaxis. That is a type 1 hypersensitivity reaction. Mainly we have four types of hypersensitivity reaction: type 1, 2, 3, and 4. Type 1 is allergy, atopy, or IgE mediated. Type 2 is antibody mediated. Type 3 is antigen antibody complex mediated. And type 4 is cell mediated or the delayed type of hypersensitivity reaction. So the type 1 is called first and fast because there are going to be preformed antibodies. Type 2 is going to be cytotoxic. So anything related to the RBC, like your autoimmune hemolytic anemia, hyperacute graft rejection, erythroblastosis fetalis, everything is going to be type 2. Type 3 is mainly the vasculitis, the polyarthritis nodosa, SLE, rheumatoid arthritis, and serum sickness. Serum sickness is sometimes asked as an FAQ. Serum sickness is what kind of a hypersensitivity reactions? Type 3. Okay, so the examples are important: anaphylaxis, asthma, allergic rhinitis, atopic dermatitis, urticaria. So anything related to allergy and atopy is going to be type 1. The RBC-related autoimmune hemolytic anemia, erythroblastosis fetalis, good pasture syndrome, because that is also antibody-mediated. You know, it's antibody against the good pasture syndrome. There is antibody against the glomerular basement membrane, right? Also, it affects the pulmonary. And this rheumatic fever, there is a cross reactivity of antibody. Hyperacute graft rejection is due to the preformed antibodies. Other types of graft rejection, when you simply say graft rejection, it's going to be delayed type of hypersensitivity. Type 3, just like we discussed, it's all types of vasculitis, the arthritis conditions, which are the antigen antibody complex mediated thing. Type 4, contact dermatitis is type 4. Allergic dermatitis or atopic dermatitis is type 1. Contact dermatitis is type 4. Tuberculosis skin test, wherein you inject a purified protein derivative into the skin intradermally, and you read it almost 72 hours later, so it's kind of a delay type of hypersensitivity. Your Steven-Johnson syndrome, the toxic epidermal necrolysis, which are like the extensive allergic or reactions, hypersensitivity reactions against certain drugs or any kind of thing, is coming under again type 4 hypersensitivity reactions. Next, we have discussed about urticaria, which we have seen in type 1 hypersensitivity reaction. The characteristic lesion we have discussed is called a wheal, and it can also show dermographism. That means if you stroke with a pencil or a blunt object over the skin, the skin can later lead to a raised lesion. That's called dermographism, which can be seen in urticaria. When it comes to eczema, what is eczema? Eczema is a skin condition, chronic skin condition, usually associated with atopy or allergy. It can run in the families. So it is mainly associated with oozing, there is crusting, there is intense pruritus, there can be erythema and edema. The lesions can be papillovesicles, and there is lichenification in chronic cases due to intense itching and scratching. It can be endogenous or exogenous. So what are endogenous eczema and what are exogenous eczema? Endogenous eczema, one example is your seborrheic dermatitis. So that is inflammatory response to Malassezia furfur. There is greasy yellow scales, especially on the seborrheic areas, on your nasolabial folds, on the over the scalp, in the all the seborrheic areas in the axilla, over the chest. You can have seborrheic dermatitis. It's a kind of endogenous eczema. There's no trigger from the external environment. While it comes to the contact dermatitis, which is a type of exogenous eczema, which is a type 4 hypersensitivity reactions, as we have discussed, it is due to irritant. It can be an irritant contact dermatitis or allergic contact dermatitis. Allergic contact dermatitis is the immune-mediated hypersensitivity, which is type 4. Irritant contact dermatitis can be non-immunological. One of the most common example being nickel, which are used in like the belt. There can be constant irritation to the skin due to this nickel in the belt, and that can lead to severe itching and scratching. That is called contact dermatitis. There is another type which is called nummular eczema, where the lesions are coin shaped. And what is the difference? Usually you see this ring shaped lesions, which are usually called the ringworm, or it's a kind of dermatophyte, okay, which is called the ringworm. What is the difference between this nummular eczema and this kind of the lesion due to the dermatophyte? In the dermatophyte, you have only the activity is only in the periphery and the center is clear. But here you can see the center and periphery both are active everywhere. It's uniformly reddish. Okay, that is called coin shaped, and the center and periphery are both active. Let's see another question. A 3-year-old child with a history of atopic dermatitis come with sudden onset of painful skin lesions of the face and neck. The mother reports that lesions started as small blisters. Okay, they were initially small blisters, quickly spread and ruptured, leaving punched out erosions with hemorrhagic crust. So this word is important. There is crust. The child is febrile and irritable on examination. You notice multiple monomorphic vesicles, pustules, and crusted erosions clustered over areas of active eczema. Okay, so what is happening? There is history of atopic dermatitis. Okay, now they have come with certain hemorrhagic crust, punched out erosions over the eczematic area. There is no significant lymphadenopathy. What is the most likely diagnosis? Now, this was a previous year question, and you only have to know you have to diagnose from the image. And the key here is there is already atopic dermatitis, and this lesions are over the areas of active eczema, and this condition is called eczema herpeticum. Okay, it's not an atopic dermatitis flare, it's not scabies with secondary infection, it's not impetigo. Impetigo also can have honey colored crust and all over the face, but it's a bacterial infection, it has nothing to do with eczema. So over the eczematous area, if you have secondary lesions, it's called eczema herpeticum. So it's eczema herpeticum. It's a dermatological emergency seen in patients with atopic dermatitis. It can be caused by superinfection with HSV1. Rapid spread of vesicles can lead to punched out erosions. It's usually common in children with underlying eczema, again over the areas of the eczematous lesions. Vesicles are monomorphic, that is, they are of all the same stage. They may need IV acyclovir if severe because it's a viral superinfection. Why not others? Impetigo, it often shows honey-colored crest rather than punched-out lesions. Why not severe atopic dermatitis? Severe atopic dermatitis again does not present with vesicles. What you have is intense scratching. You can have like a nummular ring-like coin-shaped lesions and all. You don't usually have vesicles and erosions. Scabies, they present with intense itching. There is burrows, which is the characteristic lesion, pathognomonic lesion in scabies is called burrows. There can be exoriations, but not vesicles clustered in areas of eczema. Let's talk about acne vulgaris. The treatment of acne vulgaris for different grades are very, very important when it comes to the exam. Different MCQs have been asked previously. Acne vulgaris caused by Propionibacterium or Cutibacterium acnes, and it's a chronic inflammatory disease of the pilosebaceous unit. What does that mean? Pilo means hair, sebaceous means the sebaceous gland. So it's a pilosebaceous unit which has been affected there. So it can be blocked, wherein you get in the grade 1 you get comedones. It can be blackheads or whiteheads. Whiteheads is when it's not blocked. Blackheads, it's when exposed to the atmosphere and gets oxidized, so it becomes blackheads. So it's blackheads and whiteheads which are called the comedones. That is a grade 1 kind of a lesion in case of acne. It can progress to become papules in grade 2, pustules where there is active inflammation and there is pus-filled lesions in the grade 3. In severe cases, it can be nodular cystic kind of variety in acne vulgaris. The fulminant variety is called acne fulminans. Vulgaris, wherever you hear the term vulgaris, it means a common variety of that disease. Acne vulgaris means common form of acne. Okay, just like you have your pemphigus vulgaris, because you have other varieties of pemphigus as well. So vulgaris means common variety. Now, let's see another question regarding the treatment for acne. A 17-year-old boy present with moderate inflammatory acne, including pustules and comedones. Pustules are in grade 3, right? And comedones are in grade 1. He tried topical benzoyl peroxide and topical antibiotic without much improvement. So those are like the first line. First line treatment is always topical. You can use a benzoyl peroxide, you can use a topical antibiotic. If not improved, you have to go for the next best step in management. So you have to know the stepwise approach to treating acne. We'll discuss that. So the options are add topical retinoid, start oral doxycycline with topical benzoyl peroxide, start oral isotretinoin immediately, add topical salicylic acid. So from the options you understood that the treatment options are topical treatments like benzoyl peroxide, topical antibiotics, then topical retinoid, then oral antibiotics and oral retinoid. Oral retinoid, which is isotretinoin, that is like the last resort because it has its own complications. It's teratogenic. You have to give OCPs to the patient who is taking isotretinoin. You have to counsel them to not get pregnant because it can have teratogenic effects. So these are the kind of treatments we have. We'll see how we go about the stepwise management. So what is the stepwise management of acne? We can classify acne into mild, moderate, and severe. Apart from the different grades we have, we can also classify them in terms of mild, moderate, severe. Mild means comedones with or without a few papules or pustules. Moderate means widespread papules and pustules. Severe means a nodular cystic lesion or a resistant lesion which is not responding to antibiotics. So for mild variety, which is only few comedones or few papules, you can start topical retinoid, benzoyl peroxide, topical antibiotic as well. For moderate, you can have antibiotics, maybe initially topical, and then you can go on to give oral antibiotics if it's not responding. You may have to give it for a considerable amount of time, say for example 3 months, to see if it's actually responding to the antibiotic before you go in for the next line of management. Or if it's nodular cystic, you can start giving oral isotretinoin. But with oral isotretinoin, you have to have the LFT and the lipid profile and all initially, because it can have serious impacts, and it's also it has to be advised to the patient to not get pregnant and have OCPs and some kind of contraceptives because it is teratogenic. So in this case, where the patient is having few papules and pustules along with comedones, it's a mild variety, but they have already started with topical benzoyl peroxide and topical antibiotic. So the next line of management, if it's not responding to topical antibiotic, is to start oral antibiotic. You can give oral doxycycline to the patient. That was regarding acne. Mainly the stepwise management in acne is very, very important. Next is called rosacea. What is rosacea? It is uh, the flushing and the telangiectasia, which is seen over the face, around the nose, including the nose and the nasolabial fold. That is called rosacea. So there is flushing, there is telangiectasia. Okay, unlike the comedones and the pustules in acne, this is just like the reddish lesion or reddish discoloration with flushing and telangiectasia. The treatment, topically you can give metronidazole, or systemic you can give doxycycline. Then there are pigmentary disorders like melasma, hypopigmentary disorders like vitiligo albinism. We'll discuss that now. So melasma it's an acquired hyperpigmentary disorder. So here there is actually hyperpigmentation. There is increase in melanin and there is increase in pigmentation. It's usually seen in pregnant females. So it is called the mask of pregnancy. You can call it the chloasma also. Okay, around the face when you have some hyperpigmentation during pregnancy, that is called melasma. It's seen over the malar area, nose and mandibular areas. We'll see another question. A 30-year-old woman present with dark velvety patches over the back of her neck and axilla. She's overweight and has irregular periods. On examination, the skin lesions are hyperpigmented with rough texture. What is the most likely underlying cause of her skin condition? So we are not asked to diagnose the skin condition. We are asked to diagnose the underlying cause of the skin condition. So what we have to first diagnose, what is the skin condition? The image is also given here. So it's dark velvety patch over the back of neck and axilla. She has overweight and irregular periods, which is suggestive of PCOS. So there is some kind of a metabolic syndrome happening here with hyperpigmented and rough texture over the back of neck. Here you can see this is a lesion they are talking about. So what is this? This is called acanthosis nigricans. Okay, there is hyperpigmentation or velvety patches over the back of neck, especially over the back of neck and over the axilla. You can get it in patients of PCOS, in patients of metabolic syndrome. And what is the underlying root cause of this thing? This is suggestive of insulin resistance associated with metabolic syndrome. Okay, the most common association is with PCOS and the metabolic syndrome and diabetes. You can have it with other things as well, but mainly you are supposed to rule out diabetes and PCOS in those individuals, especially if they have if they are overweight and they are having irregular periods. Always think of insulin resistance. Okay, so this diagnosis is acanthosis nigricans and the root cause is insulin resistance. What is Addison's disease? Addison's disease is hypoaldosteronism, right? So this has nothing to do with that. And that also you may have, due to raised ACTH, you may have hyperpigmentation, but it's usually over the knuckles and all. Hypothyroidism, no, not associated with acanthosis nigricans. Cushing syndrome, usually have the moon phase and the buffalo hump on the back of neck, but usually there is no hyperpigmentation as such. So this is due to insulin resistance. So this is acanthosis nigricans, most commonly associated with insulin resistance, as in case of obesity, type 2 diabetes, PCOS, and metabolic syndrome. So it's presented as hyperpigmented velvety plaques, typically over the flexural areas, including neck and axilla. Less commonly, it can also indicate gastric adenocarcinoma. So if it's a serious diagnosis, it's gastric adenocarcinoma, but usually associated with insulin resistance along with the type 2 diabetes or PCOS. In older adults, you may have to think about gastric adenocarcinoma. If at all, your main diagnosis like diabetes, if they are not obese, all those things are ruled out, you may have to also screen for gastric adenocarcinoma. That is called malignant acanthosis nigricans. So as mentioned, the hypopigmentary diseases like albinism and vitiligo, we'll see what is that. So albinism is an autosomal recessive disorder. There are different varieties like ocular albinism, which is the most common variety, and oculocutaneous albinism. And what is the main defect? It is the defect in tyrosinase. So it is from the tyrosinase, tyrosine, we are finally getting the pigment, which is melanin. So this tyrosinase is defective, so that the first step in that process is not getting, not happening. So due to that defective tyrosinase, we are having hypopigmentary lesions called albinism. We'll see a question on albinism. 5-year-old child present with recurrent pyogenic infections, particularly of the skin and respiratory tract. The child has partial albinism with silvery gray hair and light colored eyes. The peripheral smear shows giant granules and neutrophils. So this is like a syndromic association, not just purely albinism. They have albinism with recurrent infections and silvery gray hair. This is typical description of Chediak-Higashi syndrome. I just have to mention it here so that you understand what it is. That is why I put this question. The Chediak-Higashi syndrome is partial albinism with silvery gray hair with recurrent infections. It's an suppressive disorder, like there is a primary immunodeficiency disorder. So that is called Chediak-Higashi syndrome. We'll see why other options are wrong, like ataxia, telangiectasia, chronic granulomatous, and Westcott-Aldrich, and what other findings in that we'll see. Okay, in Westcott-Aldrich, you usually have eczema, thrombocytopenia, along with recurrent infections. Ataxia, telangiectasia, just like the name, you have ataxia, there is telangiectasias, right? It's a neurocutaneous syndrome. Chronic granulomatous disease, you usually have diseases due to catalase positive organisms. It's NADPH deficiency. So we'll see what is this. Chediak-Higashi syndrome, it's a rare autosomal recessive disorder. Okay, recessive disorder caused by mutation in the LIST gene. That is the gene which is affected, leading to abnormal lysosomal trafficking. It's a partial oculocutaneous albinism with recurrent pyogenic infections, especially with staph and strep. And the peripheral smear shows giant granules in neutrophils. So this is a classic description: partial albinism, recurrent infections, and the eye color and hair is also white. Okay, so that was Chediak-Higashi. Now, another depigmentation or hyperpigmented disorder is called vitiligo. So it's depigmentation. Again, the common variety is called vitiligo vulgaris. Vulgaris, wherever you here it's called common variety. So in vitiligo vulgaris, it's bilaterally symmetrical lesions. So if you have bilaterally symmetrical depigmented or hyperpigmented lesions, usually think about vitiligo. Vitiligo is not something that's spread from one person to other. Okay, it's within them, right? So it can be segmental vitiligo or non-segmental vitiligo. Non-segmental vitiligo is more less common than non-segmental, and segmental vitiligo is more common in children. It's along a spinal nerve or on one side of the body. Uh, Non-segmental can occur on any side, sometimes as a mirror image. It's also called as generalized vitiligo. Regarding vitiligo, mainly you have to know that it's depigmentation and the common variety is vitiligo vulgaris. Another important thing with vitiligo is that it shows true Cobner's phenomena. So what is Cobner's phenomena? We'll see that. Just a minute. Okay, so what is Cobner's phenomena? Cobner's phenomena means that when there is a trauma, that the traumatic areas will develop new lesions, and that is mainly seen in case of vitiligo, just like we have seen here, then in lichen planus and in psoriasis. This is where we see true Cobner's phenomena. That is when you scratch or when you have a trauma, you have development of new lesions over that traumatic area. See, in case of vitiligo, lichen planus and psoriasis, there's something called pseudocobner, where the new lesions are not due to trauma, it's due to infectious spread. Like if you have a lesion over your wrist, say you have a lesion over your wrist, and you are scratching over it, then you are likely to spread it to nearby areas due to infectious spread. It's not due to actual trauma or immune inoculation, it's infectious spread. And that is seen with molluscum contagiosum and HPV infection. So that is called pseudocobner phenomena. So that is regarding the hyperpigmentary lesions and all. The next part we'll be discussing regarding psoriasis and other topics which we have mentioned in the first session. So you can comment down below what all you would wish to see in this channel regarding Emree. If you have any FAQs, drop it down and I'll be happy to explain, and we'll be coming up with more previous year questions on different topics, especially medicine related, which I have not previously uploaded. So thank you so much. Stay tuned for the next video, and see you soon.